Okay. Yeah. Well, welcome everyone. Happy Thursday. Glad to see you all were able to make it to tonight's presentation. So, yeah, our presentation tonight is integrating CAP or ketamine-assisted psychotherapy and EMDR. So, I'm quite excited to for this presentation and to see how the two blend. And a little bit about Trauma Informed Care Network. First, Trauma Informed Care Network is a nonprofit organization. It was founded in 2013 with a mission of networking, outreach, and education around trauma and resiliency topics. We service not only clinicians, but also complementary providers and the community at large as well. So, really just trying to spread awareness. Yeah, we do offer CEUs for this presentation. One CEU is offered. If you are wanting a CEU, I'm going to type my email address in the chat box here. If you will just email this email here, it's ticnutah@gmail.com, and we will get a CEU out to you. Also, I was speaking with Kate, our presenter, and she's more than happy to share a copy of her slides as well. So if that's something that you would like, please just mention that in the email, and I'll get those sent out to you. And then last but not least, if everyone wouldn't mind putting their names in the chat box, just so we have a record of who was in attendance tonight for our bookkeeping, that would be great. And with no further ado, I'm going to go ahead and I'm going to introduce our speaker. Yeah, so our speaker tonight is Kate Kinsed. Did I say your last name right?
Kincaid.
Oh, Kincaid. Darn it, I was so close.
It's okay.
Kate Kincaid is a licensed psychotherapist and executive business coach with group private practices in Arizona and Utah. She specializes in working with LGBTQIA to S plus clients, people in ethically non-monogamous relationships, entrepreneurs, and people seeking psychedelic integration therapy. Taking her knowledge and experience of running a successful business for over a decade, she provides executive business coaching to people looking to scale and improve their businesses. She is certified in EMDR, trained in MDMA assisted psychotherapy, and utilizes ketamine assisted therapy in her practice. She also helps train other clinicians in these modalities as well. She is passionate about perinatal mental health and is an advocate for innovative psychiatric treatments for PMDD and postpartum depression. Her interest in doing relationship therapy started when she studied at the Kinsley Institute, a renowned school for the study of sexuality and gender, but flourished when she began organizing in her local queer and non-monogamous communities. She is the co-creator of Southwest Love Fest, a conference on ethical non-monogamy, relationships, identity, and community. She is the author of Polyamory Journal, a relationship book, and a contributing author to Queering Psychedelics. She's currently writing a ketamine-assisted psychotherapy companion book for New Harbinger Press. And with no further ado, Kate, I will go ahead and turn the time over to you.
Thank you. It's always kind of awkward to hear your bio, but thank you for introducing me, and thank you everyone for coming. Um, Before I share my screen, I just want to get, if you can raise hands, I'm just curious about experience with ketamine and EMDR in this group, so I can kind of tailor how much time I spend on each. Um, So, how many of you are already trained in CAP or experienced with CAP? Maybe raise your hand. Three. And how many of you, oh, four. How many of you are trained in EMDR already? Okay, more people in EMDR. And has anybody utilized CAP and EMDR together? Kristen and Corlin. I recognize your name, Corlin. I don't know if I'm saying that right too, but I think maybe we've corresponded.
Correct, yeah. I think because we were both MAPS trained.
Oh
Yeah,
yeah, yeah.
yeah.
That's right. hmm Okay, so but just Kristen has experience combining CAP and EMDR, is that right? Or did somebody else? Okay.
Me as well. Yeah.
Oh, you too. Okay,
Yeah.
great. Cool. Okay, well, hopefully it won't be too much repetition for you two. Or like, I also like a lot of questions, so feel free to put them in the chat, interrupt me. I want to leave time at the end for questions as well, so we can just have a discussion, especially those that are already practicing, if we want to talk about a little bit more in depth. Great. So I'm going to share my screen. How's that? Can everyone see it? Good. Okay. I'm going to close the video boxes so I won't see you. But like I said, feel free to put things in the chat or just unmute and ask questions. I like them throughout. Okay. So yeah, no more on my intro. And I just wanted to give a disclaimer that this training reflects my clinical experience and my learning across multiple modalities and professional trainings. It's intended for educational purposes only and not designed to teach, replicate, or substitute for any proprietary, trademarked, or branded therapeutic protocol. And just a brief intro to psychedelics that I like to talk about. The term psychedelics means soul revealing, which I like to remember. And I also think therapy is soul revealing. So the psyche or mind or soul, psyche means mind or soul, and delos or delic means to reveal. And psychedelics can be synthesized or obtained from natural species like mushrooms or ayahuasca. Ayahuasca is interesting because it's a little bit of both, like it is natural species, but you do have to mix it together in order for it to become psychoactive. So it's a little bit of synthesis too. Um, Psychedelics induce altered states of consciousness, psychological or physiological. And another name for them are entheogens, which means generating the divine within. And there's been a lot of we're in a psychedelic renaissance right now. There's been a lot of studies examining what happens on the in the brain and the neurological level. And one of the common agreement is that it quiets the default mode network and creates and helps create neurogenesis or new pathways for healing and new beliefs. So why ketamine? Because it's currently the only legal psychedelic in all 50 states for use in healthcare settings. That's changing, as I'm sure a lot of you know, in different states. Some you can use psilocybin. Um, Now there's a lot of talk about ibogaine. So that is changing. But right now, ketamine's what we have readily available. That's so when I first heard about ketamine, I wasn't that excited about it. This was like a long time ago now, but I was like, well, I'll get trained in it because it's available. Um, and as you hear, and some of you may already know, like not just is it available, it's also an awesome medicine and has a lot of exciting uh, benefits. And one of them is that it's neurogenic or it promotes synaptogenesis and neuronal branching. So it's like brain fertilizer. Um, it's also a molecule that has a novel mechanism of action. So it's not serotonergic like a lot of psychedelics are. So it doesn't operate on the serotonin network in the brain, which is exciting because people who are on SSRIs can still engage with ketamine. I think somebody might be unmuted. I don't know if you can mute. Or I'm hearing feedback. I don't know if anyone else is hearing that. Um, so yeah, it's exciting because people who are on SSRIs can still engage with ketamine. Whereas with other psychedelics that are serotonergic, it's advised to taper or go off of your SSRIs to avoid serotonin syndrome, which is really rare. What's more common is that people who are on SSRIs don't feel the medicines that are serotonergic. Ketamine also has a shorter duration than other psychedelics, so sessions can be 1 to 3 hours rather than a 6 to 8 hour experience. And what I'm excited about is that it tempers the limbic system, which is a great tool for processing trauma. So, people that might normally get flooded by something, they might be able to access that material when ketamine's on board because there is that tempering of the limbic system. Okay, so ketamine-assisted psychotherapy. I like to remind people that ketamine is just the tool to facilitate the psychotherapy. So, as I'm sure you all know, there's lots of different ways that ketamine's being done. And when I meet clients that say they've done CAP, I have a lot of questions about, well, like what kind of CAP, what did that involve? Was there integration? Was there somebody with you the whole time? Um, or were they watching a movie while they're on ketamine? Like there's just a lot of different ways that people are using ketamine. Um, the way I like to use it is similar to the model that's being used in the clinical trials with MDMA and psilocybin, where there's a facilitator, usually like me if it's, as a therapist, or in my practice, everyone's licensed therapist that does CAP, sitting with the person the entire time. And the person can talk as much or as little as they want. And this I'm kind of talking about psychedelic dosing, and I'm going to get into that, like the difference between psychedelic and psycholytic dosing. So psychedelic dosing is a higher dose, a longer session, and usually people are kind of off more in their own world, where psycholytic is a smaller dose. They maybe can talk and engage the whole time, have their eyes open. So we'll get more into that in a minute. And the ketamine itself aids in symptom management, but the aim of CAP is healing the underlying causes of the psychological distress, which is frequently related to developmental trauma. And I like to say that therapy is actually the more potent psychedelic. So the ketamine is just this little assistant that we have to help us do the therapy that we're already doing in a different way. So here's just how it looks in our clinic, one of the rooms. We also have rooms that have reclining chairs for people who don't want to get on the floor, but we give people the option, and a lot of people prefer the floor because they say you can't fall off the floor. And ketamine, sometimes they're, even though people look very still, in their body, it might feel like a lot of movement, and it just feels like really literally grounding to be on the floor. So we do like a trifold foam mattress, set it up like a bed, sit on the floor with them. And yeah, you can see there's a little altar that we've set up and invite people to bring their own um, contributions to the altar, like pictures or little figurines or crystals. Um, and that also can help with integration because they can bring that item back and put it on their dresser or their nightstand and kind of help them remember the journey that they're going on. Okay, so some of the best matched approaches for CAP are anything non-directive, mindfulness-based, and trauma-informed. Anything that allows that inner directed healing work and builds trust in the inner healing capacity. Um, Mindfulness-based practices, sensory motor psychotherapy or somatic experiencing goes well with CAP. Internal family systems, we see a lot of parts come up or parts work come up naturally. And so having some training in that or ability to talk in that language is helpful. And then, of course, what we're talking about today is EMDR. So I'm going to talk about how EMDR can be integrated in both the psychedelic dosing and the psycholytic dosing. So remember, the psychedelic is the higher dose and the psycholytic's the lower. Okay, so I talk about this with clients in the preparation too, but just remembering our roles and that we each have different roles. So as the clinician, our role is to hold space, create a safe container, explain when and how to ask for support if needed, manage the time, manage safety, so making sure they don't drive, not standing up until they're ready, or if they need help when they stand up to go to the bathroom, track what the client says and record. I tell them I'm kind of like a transcriber. So I'll, as they make noises or have insights, I try to jot those down. Um, and I'm kind of talking about the psychedelic dosing right now. And then just reminder for clients to surrender or allow whatever's coming up if possible and go into whatever's coming up. And then for clients, their roles are to practice asserting their needs and requests. That could be like they are cold and they need another blanket, or they need a sip of water. Um, and so we make this explicit, like, this is a time for you to practice doing this, especially if people struggle with this. And their role is also to surrender to the experience and trust their own inner healing intelligence, give feedback to the guide if necessary, like you're talking too loud or the music's too loud or too soft, and follow whatever's coming up. And with the EMDR term, just go with it. So we talk about this with clients. And it seems like a lot of you already know this, but I like to just describe the subjective experience of ketamine, and it can be different for everyone, but there's a lot of similarities that people describe. So a lot of people say it's ineffable, so difficult to describe in words. It feels expansive. People might experience a sense of boundarylessness or formlessness, altered proprioception, so, not really in their body or how their body is in space, um, reduction in limbic activation and a lowering of anxiety, especially at low levels. Ketamine is definitely very anxiolytic, or can be. Not for everyone. Some people have the opposite effect, but most people feel calmer, a little sedated. Synesthesia, so that's the crossing of senses. So, like tasting or smelling color can happen. Um, there can be a lot of movement, not literally with the body, although sometimes people are moving, but in it feels like movement. So that's why also sometimes people get nauseous with ketamine, or if people are prone to motion sickness, we might have them take like Zofran or something to prevent nausea because it feels like a lot of movement. Some people say that feels like a fun ride, the movement, and some people feel nauseous from it. Feelings of peace and okayness, that's a common uh, feeling that people describe. And the psychoactive effects last about 45 to 90 minutes with a psychedelic dose. That all depends on the route, and I'm going to talk more about the different routes in a little bit too. So yeah, here's the different routes. So there you can have IV ketamine, that's it's injected right into the vein. The onset is in seconds, and when they turn it off, it goes away right away, um, or pretty much right away. And then it's about 100% or near 100% bioavailability. So every bit of ketamine is going into the body. Intramuscular is like a shot in the arm, like a vaccine. Its onset is about 4 to 5 minutes. Um, and the psychoactive duration is 12 to 25 minutes. So it takes a little longer to get out of the body than IV, but it's shorter than oral, which I'll get into. And that's about 95% bioavailability. Intranasal, like Spravato is a pump, or like an inhaled pump. Um, and yeah, it's about 50% bioavailability. Onset's 4 to 10 minutes. And then oral, which is really common, and a lot of therapists in private practice are practicing CAP with oral ketamine, where they have an outside prescriber, and the person gets the prescription, brings it in, and self-administers it. And that is in like a little troche or lozenge. It's kind of like a waxy, or it could be hard, or it could be powdered, like pressed powder. Um, or liquid suspension. I haven't really seen that as much. And it's put into the mouth and absorbed through the oral mucosa. It could be spit or swallowed. Swallowed, I tell people sometimes that experience is going to last longer, and they might get like a second pass, we call it. Like, so you get whatever's absorbed in the mouth, and then it goes into the stomach, and you get another dose, like when it hits the stomach. So it's kind of based on client preference, what they have going on that day. Can they afford to feel altered for longer? Um, so that we talk about all that. They talk about that with their prescribing provider. They might talk about it a little bit with the clinician, but we always want to make sure we stay in our lane and not advise people on how to take their medication. That's between them and their prescribing provider. With the oral troche or the oral ketamine, the duration can be, I say 1 to 3 hours, but that's the whole session. I'd say it's more like 45 minutes to an hour of the psychoactive phase. And there's a wide variety of bioavailability because people have different gut mobility or motility. I don't know the word, but it's their gut is absorbing different amounts of the medication. Okay, and integration is super important. I'm sure those of you in the psychedelic world hear that all the time. But I think it's important to review this with clients because a lot of clients coming for CAP are new to psychedelics. They might have, watched a Netflix thing or read a book or they've read some articles about it, but they um, don't really know what that means. And so I spend time in preparation talking about integration and why it's so important. And that's kind of like what I was saying before. The ketamine is just this little assistant that we have. The real work is the therapy and the integration practices that people implement during therapy, after therapy, in between sessions. And so I like to just really educate people on that if you want the long-term benefits, you have to put in the hours, you have to put in the work, not just come for the ketamine and take the ketamine. For psychedelic dosing, I recommend to do at least one integration session after each CAP medicine session. So integration happens also right after, like post ketamine administration. So when people are coming out of the medicine, that is integration when they're starting to talk, share what that journey was like for them, share any insights they had. They're already starting the integration process. But then I think it is important to meet again within 24 to 72 hours after that medicine session when they're not altered and they've kind of lived a little bit of life in between and seen if there's any effects or what, how they're maybe responding to conflict differently or how they're noticing their responses to like what they think about might look differently. And that's what we can talk about in that integration session. Um, for psycholytic dosing, that's like the lower dose. I don't think it's necessary to do into like a separate integration session because they are talking a lot more because it is a lower dose. Um, and so you can just be on your regular schedule of therapy after a CAP session. Um, Integration can be done with a supportive existing therapist or a therapist that specializes in integrating psychedelic or extraordinary states. I think this is preferred. If somebody has a primary therapist that um, doesn't have specialized training or personal experience, I think it's important that the client is integrating with somebody who does have that experience. So I encourage therapists to get the training or, um, do kind of like that bubble work of like the CAP and the integration with a therapist that specializes, and then they can go back to their ongoing like long-term therapist if they want later. And then I like to remind people there's lots of other ways to integrate besides just psychotherapy. Dancing, drumming, walking, meditation, talking to peers, art, journaling, collage. And some of these things, like in my clinic, we do group CAP and in individual and group, we always give people blank paper to draw or color right after the session because sometimes the words are not coming and we don't want to rush people to put words to something. Maybe they want to just draw it out or like do some movement with that. Um, and then archetypes with like collage, like just finding images can be really powerful if they want to kind of recreate what they saw, which is sometimes beyond words. It might just be colors or shapes. And so that's why I like collage a lot for that. Making an altar again, and this is, if somebody doesn't want to do this, it's not like it's advised that you have to make an altar, but if it resonates with people, encourage them to make an altar on their dresser or something that just kind of helps remind them of the work that they're doing. And also playing the same music. And so we'll send people the playlist after, and that sometimes can jog their memory too. Like they, might have remembered a few insights and then they're listening to the playlist and that song jogs their memory and they're like, oh yeah, I saw this whole scene of my life at this phase, and they can bring that to integration therapy. A group integration can be very healing, affirming, and reconnecting to community. At my clinic in Tucson, we had Psych NP students working for our clinic for a while, and a couple of them did their dissertations on the work that we were doing. And we did some pre and post PCL5. And so one student did one just on individual CAP with the PCL5 before and after 6 sessions of CAP. And we did see a significant improvement in their scores, and especially what was it? Yeah, so we saw a significant improvement. And then another student did one between individual and group CAP, and we saw an even bigger improvement in, I think it was question 13, which is about feeling connected to others. And so I thought that was pretty cool. Okay, now I'm going to get more into the EMDR stuff. Any questions so far? I haven't seen anything in the chat. Okay. So I think a lot more of you were already trained in EMDR. So you already know about the adaptive information processing model. I like to just explain it to you guys. I always like hearing other people explain it because I feel like we all have different ways of saying it. And when I hear other people describe what AIP means to them, it usually just I learn something new. So it's the theoretical foundation of EMDR. And for those of you that aren't trained in EMDR, this is new for you, I guess. So it's the theoretical foundation of EMDR, and that is that human brains have this innate ability to process information in an adaptive way. The trauma memories are stored, and I say kind of stuck or frozen in the neural network of the brain. The memories of the traumatic events are connected to a negative cognition or belief about self, feelings, and body sensations. They're all kind of like packaged together, stuck in this network in the brain. The goal of EMDR is to have a disconfirming experience and add in adaptive emotions to the neural network. So, like when people have all of those things kind of stuck together, the way they see the world is always confirming that, like they're looking, it's like confirmation bias. They're looking for proof that they are a bad person or that nobody loves them or that they can't trust these people. And so the goal of EMDR is to bring in adaptive information, that like positive cognition that, I trust myself, or um, I am safe, or whatever it is that they bring in, and we want to disconfirm some of those negative traumatic beliefs that are stuck together. It's similar, I think, to the belief in many psychedelic assisted therapy frameworks about an inner healing intelligence. So with EMDR, a lot of the advice is just go with it. Like, don't add meaning, don't guide. I mean, we do a little bit of guiding in EMDR, but it's really, we're just getting out of the way and letting the brain process in the way that it needs to. We're trusting that that person and their brain knows where they're going, knows where the memory networks are that they need to address or heal. And we're just kind of staying out of the way. So I think that's why EMDR and CAP go so well together, I think. And we're trying to get those maladaptive and adaptive neural networks to link up, and that is integration. So there's that word integration again. So we're trying to get these systems to link up in a different way. Any thoughts on that? I would love, maybe if we have time at the end, I'd love others to hear how others describe the AIP model. Okay. So talk a little bit about memory reconsolidation. So, one of the ways, that I think, or that they're saying, there's been studies, there's lots of studies. At first, I know people said EMDR, we don't really know why it works. We think it's like related to REM sleep. I know this was like back in the day. And now there's a lot more understanding about it and people talking about memory reconsolidation. So it's about how traumatic memories are held in the nervous system and how they can be experienced or organized differently over time. So it's a neurological treatment resulting in cognitive shifts due to this memory reconsolidation. So basically, the maladaptive memory, like that memory of the trauma where everything's stored together, is activated, retrieved. We're going to bring it up. Um, work with it, and it's temporarily changeable, malleable. Clients have a new experience in therapy sessions, so that's where like I love when you see clients like own adaptive information comes on, like, oh, I was really there for myself, or they see a scene, a traumatic scene, and they forgot that like their grandma was there and like that they did have somebody that was looking out for them. And so it's just cool. Those of you that practice EMDR know like how adaptive information just kind of pops up sometimes. And then it's also introduced through like choosing a positive cognition. So we bring up the memory, we activate it. We introduce that adaptive information, and then the new memory is restored in an altered form. Um, that's kind of what memory reconsolidation is, and how it helps clear things. That's the word they use in EMDR. It's a dynamic process that literally changes the memory in the brain. Okay, so ketamine, a little bit more on the uh, brain science of ketamine. It increases glutamate, which impacts memory and information processing. And this is what we're working with EMDR is the memory and information processing systems. So that's why another reason why they work well together. Ketamine increases BDNF, which is brain-derived neurotropic factor, which some people also call brain fertilizer, and that's kind of what helps, they think, stimulate neuronal growth so that new neural pathways can be created. And because of this neurological feature happening in the brain, old memories become less powerful, the brain becomes more flexible and open, and neurogenesis creates new neural pathways. Um, Ketamine reduces, like a lot of other psychedelics, that functional connectivity in the default mode network. That's a DMN, the default mode network. And so that's kind of that, the default mode network is that it's kind of like our personality. It's like our normal way of acting. It can sometimes be self-referential, ruminative, um, and that we see more of that like with PTSD, with depression, especially treatment-resistant depression, like people are really stuck in that ruminative cycle. And so ketamine reduces that, reduces those, like those pathways are so well worn that they're really connected. And so ketamine kind of helps like break those connections down a little bit. For clients with PTSD, ketamine's ability to temporarily reduce fear and hyperarousal might help them engage with the traumatic memories. So again, like I was saying, that it tempers the limbic system. That's why I'm excited about working with it with trauma, because um, it may allow them to access more material without the body, um, hijacking or not the body necessarily, but the brain, the amygdala, like hijacking them and flooding them and having going outside their window of tolerance. And so, in that sense, ketamine widens or can help widen the window of tolerance. Okay, so as I've mentioned already, there's different ways that the ketamine can be dosed, not just the route, but also the amount. So psycholytic is lower doses with greater frequency, often, not always. It allows for clients to work directly with material while ingesting the medicine. So they aren't necessarily often some world that they're just on the ride. They're like sitting up, having a normal conversation. So that can happen with the psycholytic dosing. Clients can maintain their capacity for dialogue and awareness of the space. And then with psychedelic, these are higher doses where people often experience sometimes being out of touch with their bodies. Although I will say with the oral route, I noticed that is more somatic. Like sometimes people leave their bodies, but a lot of times people have body sensations are a big part of their experience too. But depending on the dose, can lose touch with the physical realm and detach from a prior sense of identity, like for the moment while they're on the psychedelic dose. So with psycholytic dosing, the EMDR can be done during the ketamine ingestion. So on low doses of ketamine, you can do the EMDR phase 4 BLS reprocessing while they're on the ketamine. With psychedelic dosing, I've heard different things, but most people that I've talked to agree that it's not ideal to be doing EMDR while somebody's on a high dose. I actually had a client who was a therapist and trained in EMDR, and she loved EMDR, and she brought in her tappers and wanted to do continuous tapping while she was on a psychedelic dose. And like as soon as the medicine came on, she threw her tappers across the room and was like, no, I don't want to touch those. So it's just, I just think like it's back to that non-directive approach. Like you have no idea where people are going with the psychedelic dosing. And so even though EMDR is also a little bit non-directive and like letting people's brain do the work, it it's still like you're trying to do an activity when that person is just off in their own world and not necessarily ready or interested in doing a treatment modality like that. Um, so I think EMDR with psychedelic dosing, EMDR works really well for integration sessions. So like maybe you've done some EMDR, they do a CAP psychedelic dose, and then you can pick back up the EMDR like that 1 to 2 or 3 days after the CAP session, and their brain is still kind of open and in that neuroplastic phase, and the EMDR can be really supportive at that time. Okay, so the psycholytic dosing approach is not new. It's been used for a long time. It allows for more therapeutic interventions while on the medicine. So, like I said, because they have the medicine on board, but like from the outside, so if you didn't know, you might not even know that they're on a medicine. That's how the psycholytic dosing works. Um, So they really can participate in just a pretty much normal therapy session. They might speak slightly slower. Their body might be like a little bit more relaxed. But yeah, pretty much you can have any normal session. It's harder to engage with EMDR processing, like I was saying, on the psychedelic dose. And even right after a psychedelic dose, like I've tried that before too, where somebody has a psychedelic ketamine experience, and then there's about an hour. If I do a 3 hour session, there's about an hour at the end where it feels similar to a quote unquote normal psychotherapy session, although they are a little bit more relaxed. Talking a little slower. Um, and yeah, people aren't really ready to jump into EMDR at that moment too. So I don't recommend doing that. And with the psycholytic dosing, you may only need like 60 to 75-minute sessions, which increases accessibility. And people can maybe use their insurance. Whereas with 3 hour session, as you know, insurance only covers one uh, 53-minute session a day. Um, so yeah, having the psycholytic as an option might increase access for clients. Also, not just about the money or the time, but maybe they're not really ready to fully dissociate or go into a whole nother realm or world. Maybe they have no psychedelic experience. And so this psycholytic dosing is more gentle. It's a gentle introduction to the psychedelic work, which is more approachable for some people. And even if people like in our clinic want to do a psychedelic dose, sometimes even like the first session if they're scared, we'll talk about basically doing a psycholytic dose or just a lower dose, maybe between a psycholytic and a psychedelic, um, just as like a handshake with the medicine and just to kind of ease that anxiety. Okay. All right. Let's see. So, yeah, the timing of EMDR. So, I was kind of mentioning with psycholytic, you can do it while somebody's on ketamine. With psychedelic, you do it after. Um, when, um, yeah, and there's different times that you could implement the ketamine. It could be at the start of a session, it could be after you're setting up the target. Um, and yeah, but it could be done during the peak experience for lower dosing. Okay, I already said that. Um, So yeah, so some clinicians activate the memory before the altered state. Others work with material that emerges spontaneously, especially with the psychedelic dosing. You're just kind of going with whatever comes up. Some defer trauma processing entirely during the medicine session. Um, so, somebody's bringing up, telling you like what they're seeing, it's a traumatic memory. Um, just kind of like asking them, where they feel that in their body, or, you know, encouraging them to just keep going with that, but not necessarily like trying to make any sense of it or process it in that moment. It's just like noting that it's coming up, and then you talk about it later in integration. And that kind of just depends on the client and where they're at, of course. And always decisions are influenced by dose, client history, their preferences, and the therapist training. So, review of the 8 phases of EMDR. So, the first one is history taking and treatment planning, preparation, assessment. That's where we're identifying targets. And then 4 is the desensitization, or where we're doing BLS, um, movement, bilateral stimulation movement, whether that's with your hand or light bar or tapping or buzzers. And then installation, where we're installing that positive belief, body scan, closure, and then the next session is reevaluation. So you're checking to see if that target memory was cleared. And in my training, I did a training through the ketamine, I think it's KA-EMDR, so ketamine-assisted EMDR, um, where it was like a whole 6-hour training. And they were proposing to put the ketamine here in between phase 3 and 4. And they had a lot of good reasons for that, where they want, based on like some of the research they had done, we wanted to activate the memory, which makes sense if you give the ketamine too early, people are not going to be activated because it has that anxiolytic effect, where people, it might still be a great session. You can still do EMDR, you could just do talk therapy if somebody's not activated. But with EMDR, there is some research to support that activation is key. We want to bring up the negative memory that's frozen and like all the activation that's associated with it to have that disconfirming experience. So they were saying we want to bring up the target memory, activate it, then ingest the ketamine and help, and then move into the EMDR processing. But I think people are doing it all different ways, like I said. So that's just one way of doing it. Um, And then these are the review of the phases of psychedelic CAP. So we do the history taking and treatment planning, assessment. So just like EMDR, we're kind of assessing for their resources, internal and external resources. Can they do state change? Can they do calm place? Can they, regulate themselves when they're overwhelmed? Um, and we assess for that in the initial assessment with the nurse practitioner, but also just in preparation sessions. And that can help decide the course of the treatment too. And then the medicine sessions, and then after each medicine session is integration. So like in step 6, we want to repeat 4 and 5 for each CAP session. Like I think it's important to always put an integration session with a medicine session. Okay, so clinical considerations, just always remembering client orientation and consent, remind them that they're in control. This is even more important, I think, when engaging with psychedelics, because people are more open, people are more sensitive. So we just really want to have good boundaries, talk about everything, talk about consent, talk about touch consent. Like we have a whole touch consent a separate agreement that we go over, like because especially in psychedelic CAP, like big emotions come up and people might want their hand held, or they might ask you to like hold their shoulder to ground them. And so we talk about all that before going into a session. And you never, and part of the consent is, what we agree to now when you're not altered, we don't change that after you're altered. So if you say you don't want me to hold your hand, and then you're in the ketamine experience and you reach out to hold your hand, then I'm not going to hold your hand. And so just um, really like kind of driving that home to people. Um, and ketamine can soften and it can soften protective parts or systems, and we don't want to blow past them. So we never want to use ketamine to get through a protective part. The person might be choosing to use ketamine to understand or get more familiar with protective parts. But if somebody's feeling unsure and they really don't want to do it, we don't want to just say, oh, just trust the medicine and just go with it. It's like, let's talk about those. Like, what are you feeling nervous about? What is this part trying to help you see or trying to make sure it doesn't happen? And just spend a lot of time um, going into that with people. Um, I think it's important to vet clients and work with people who are ready and willing. Like, I don't know if those of you are already practicing CAP, if you've seen this, but um, I've seen, in our clinic, sometimes people they call and they want to do the ketamine and then they're like, well, can I just skip the integration part? Or I only want to do the ketamine. I don't really even want somebody in there with me. And we just do a lot of education that that's not how we practice at our clinic. We don't give them the names, but there's lots of places that you can just go and get ketamine. We don't even necessarily say that, but we just say we're not a place that you can just come get ketamine. Like we're here for the therapy is the focus and the ketamine's the assistant. And so that's a way to vet people. Like this would be an expensive way to just get ketamine. Like it's a lot of hours of therapy that's not even covered by insurance. And so just seeing if people are willing to put in those hours and do that therapeutic work. So that's important. I think we have like a screener for that, and that comes up kind of in the intake and in the preparation sessions. Like, are people ready and willing? And sometimes in those prep sessions, we discover they're not, and we pause and we don't push forward and keep going. Maybe they keep working with their therapist for longer until they do feel ready to go into the CAP or CAP EMDR work. And then, yeah, I kind of already mentioned the informed consent, but um, yeah, just letting people know like what's going to happen, what their alternatives are. I think maybe I even have a slide on what goes into an informed consent. With EMDR and CAP, I think it works best when they've done some EMDR first, so they know how it works, they know what it feels like. Um, Not to say that you couldn't do your first EMDR with ketamine on board, but I feel like it's just, in my experience, it works better if somebody's done EMDR first and then you add ketamine. Ideally, it's kind of great when people have done EMDR and like psychedelic ketamine and then do the CAP and EMDR together. It just kind of, I feel like in my experience has worked well. But like I was saying with the psycholytic dosing, like some people aren't ready for a psychedelic dose, and that's cool. And it's a great way to start with a psycholytic dose. Okay, so a little bit more on the client vetting. So if they're motivated, desire to do the work, um, and I don't know if any of you work with teens. We have had a few teens come through our clinic, and I think especially like assessing like for their consent, like if or is this the parents like looking for a solution and trying to kind of push or encourage the teen to do the work. And so, yeah, just taking the time to really see like, is this what you want to be doing? What do you think about this treatment? Like, what are you hoping for? What do you think it could do for you? And just taking it slow. Making sure, some people do come in seeking a magic pill or a quick fix, or like this is like a Hail Mary, like last shot. Like I've tried all these things and nothing's working. And so this needs to work. And we try to like, we don't want to like crush their dreams, but also like um, just try to like introduce the concept that like this is not a magic pill. That this is just like I said, an assistant, or it just I say it kind of illuminates the path of the work that you have to do, but then you have to like do the work and keep going. And um, so yeah, just again, just I feel like kind of a broken record sometimes, just educating people on that. Ideally, people have tried several or a couple at least medications or therapeutic modalities, and so that's speaking to that treatment resistance. I don't think that it always has to be like officially treatment resistant for people to do ketamine, but ideally this isn't like the first thing that they're trying. But yeah, so they've tried some things. Especially people who have like a good foundation of psychotherapeutic work, also, I find like kind of go on the springboard of ketamine and get like a lot more benefits than people who have not done very much psychotherapy. Um, yeah, but they're still suffering from depressive symptoms with or without suicidal ideation, anxiety, PTSD, developmental trauma, mild to moderate OCD, and trauma-related disordered eating. Yeah, so here's a little more on informed consent. And I could share ours with you if you want, if those of you who are like just getting started. Um, so yeah, you want like a little bit about what ketamine is, what is CAP, what is EMDR, and hopefully you're also talking about this a lot and maybe sending videos or more resources, but your informed consent should have just a little bit of a description of it, how it's administered and at what dose, how many and how long are sessions, the benefits and the risks. We always put like that off-label explanation between like racemic or generic ketamine it's an anesthetic, so that's what it's approved for. But we're using it off-label, so we'd always put like an explanation in there. But there's also uh, FDA-approved ketamine, which is Spravato, which is that nasal pump. But that is, and I can talk more about this if people are interested, but it's only approved for treatment-resistant depression. It can only be administered in a certain way. There's no ongoing therapy with it. And so that's just like a totally different ballgame than kind of what I'm talking about. And then also in the informed consent, giving them alternatives, which a lot of them already know alternatives, or some of them have even done these alternatives. But just I think that's important in informed consent. Like this is not the only way to treat your symptoms. Um, so some of the contraindications, so things that would make us pause or not have somebody proceed with CAP would be uncontrolled high blood pressure because ketamine does increase your blood pressure. Um, and cerebrovascular risks, like if somebody has a history of a stroke or an aneurysm, they wouldn't be a good candidate for ketamine. At least not in our clinic. They might be a good candidate for like an IV clinic that has an anesthesiologist on board or somebody that can administer rescue meds if needed. But at our clinic, we only do IM and sublingual or like the oral ketamine. So we exclude people that have those risks. Certain cardiovascular conditions. So if people have heart conditions, we will sometimes have them get permission or approval from their cardiologists. And if the cardiologist says they're good to do ketamine, we would do it. With them, like at our clinic, we have two tracks. We have the IM where the nurse practitioner is administering. If somebody has health conditions that are a little bit more higher risk, we would have her do it so that, she's just more medically trained. People who have lower medical risks can do the self-administration. There's no psych NP on site. It's just the therapist where the client is self-administering the medicine. For now, psychotic disorders are a contraindication, like schizophrenia, active mania or hypomania, or unmanaged bipolar. It's not necessarily a no forever, but we would want to make sure that there's a mood stabilizer on board for the duration of the ketamine treatment because ketamine can induce mania, especially in people who have a history of that. So that's kind of more of like a yellow flag for us. And if the person's on mood stabilizers, um, they might be able to proceed with ketamine. And any active or chronic alcohol or benzodiazepine abuse, people have to be able to abstain from alcohol, benzos, and opiates before and after the ketamine. And we wouldn't want somebody going into withdrawal. And also, if they drink or something like right after the ketamine, they're just not going to. And we've had a couple of clients like this, like they were able to abstain, but then they drank like a day or two after the ketamine and they just we didn't really see um a lot of change. And so we just kind of talk about that with them, like it can be helpful for addressing those conditions if they have enough ability to uh stay sober to do the ketamine treatment. So that again is also kind of like a yellow flag. And then pregnant clients, we don't do ketamine on, but if somebody just had a baby, we we can do ketamine. And there's one study about ketamine in breast milk, and we give that study to people, let them decide if they want to pump and dump or if they are okay with the small amounts of ketamine that goes into the breast milk. So that's just kind of something that we have to educate people about. Okay. In the prep sessions, we're collecting all the biographic, and this is for EMDR and CAP, collecting the biographical information and assessing their resources, identifying goals for treatment, coming up with EMDR targets, intention setting, like what are they hoping to get from this treatment, pre-session journaling and activities we might go into in the preparation session, and then a lot of day of logistics, especially with the psychedelic ketamine, just telling people like what to dress, bring a blanket if you want, how to hold their medications or hold food and drink um, so that they can go into the CAP experience. And aftercare instructions. So we have a whole handout on people, I mean, to give to people that, um, how to take care of themselves after a CAP session. We talk about integration in the prep sessions, that how important it is to show up to those, to do some work in between sessions. And then we also sometimes include family prep, like what have you told your family? How do they feel about you doing this work? Um, are they supportive, or is there somewhere else you can go for a few hours after your CAP session where if they're not supportive, if they're going to give you the side eye when you come home, like how do we plan for that and prepare? Okay. Yeah, so in that prep session, also just explaining the logistics of a session. And then for the actual CAP EMDR or just CAP session, thinking about the room setup. So just like with EMDR, regular EMDR, you want to see like how close do you want to sit to the client? If you have tappers that have like a cord, just making sure like the room's all set up for that. For the day of vitals, a lot of people don't do vitals, but we do still, especially for psychedelic caps, where clients will take their own blood pressure and pulse, and oxygen levels. So we do just making sure that's all set up. For psychedelic cap, we also, if they want, do like an opening of a ceremony, like make it very ceremonial, which just kind of helps like be in that non-ordinary state of consciousness. So just add a little bit something different to the session. Um, if you're doing EMDR, you want to check on the speed, intensity, and type of BLS, just like you would with normal EMDR. Identify the time of swishing. How long are they going to swish? It's usually like with EMDR, it's usually like 10 minutes. Just decide if they're going to ingest the medicine or spit it out. And like, if they're going to spit it out, make sure you have the cup ready and all that. Um, for music, we wouldn't really use with like psycholytic or EMDR cap. But with psychedelic, music is a huge part of it. It really guides or helps support the journey. So you can talk about preferences. We have a lot of playlists already made, like from staff or even clients have made playlists, or there's like a lot on Spotify anyway. Um, and yeah, just picking out the music, making sure they're okay with it. Like, do they prefer more nature sounds, or do they like more drums, or they might have a playlist that they prefer. You want it to be something in a language they don't speak, or no words. So because if it's in a language they speak, that kind of it can pull them out of their experience and start using that language processing part of the brain. Um, Discharge protocols, yeah, just talking to them about the discharge protocol is going to be making sure you can walk or ambulate on your own, that you can tolerate food and water, go to the bathroom, that your ride is here, all that. And these are the aftercare instructions that we give to people. So have a restful afternoon and evening if possible. I always tell people to try to do something different, like to kind of capitalize on that neurogenesis. So, if you usually go home and watch TV, try not to do that tonight. Try to read instead, or go on a walk, or do some art, or, sit with your kids, or do something different, maybe that you would than your normal routine. Even like taking a different route home, going to a different restaurant, like those are all ways to kind of like just encourage that like neurogenesis. Um, Ensure that your partner, your family is supportive. If you can, try to avoid conflicts, or like if that person's not supportive, like I said, trying to find like, can you stay at somebody else's house that night? Or, um, if it's a mom, and I work a lot with perinatal, and, is there making sure you have somebody to watch your children for the rest of the afternoon if possible. I know a lot of times it's not possible, but just really trying to like carve out time for people to like, and we probably do this with all therapy or all EMDR too, because people are really sensitive after, but just really, especially when ketamine's brought on board, like really carve out that time to like give yourself the space to process what you just went through. We give them journal prompts, or they can just journal freely on their own about their thoughts or their insights from the session that day. I take pretty good notes, like especially if people like have an aha moment, and I'll send them that transcript, and so they can kind of hear in their read and see in their own words. What they came up with, the gifts from their own psyche, like the insights that they got. You can return to regular activities the day after treatment, although we recommend trying to take the next day if you can to rest, which is a lot to ask for a lot of people. But and that's why it's a lot of people want to do them on Fridays, because then they can kind of rest on Saturday. Some people feel more activated and energized after their session, or like irritated. So even though ketamine is anxiolytic, it is activating. And so some people feel like a little bit of agitation. I also noticed this like with people who say, "Oh, it's not working," but they're like really agitated. I try to do, I'm not trying to tell them, "Oh, it is working because you're agitated." It's like later telling them that might have been like what was happening for you, and like they just don't necessarily know how to like soften into it or go into the medicine, or the dose might be wrong. So that can all be like kind of discussed and understood in the integration sessions. Encourage the use of calming activities like journaling, meditation, exercise, rest, bath, distraction. Arrange for a family or friend or family member to be available. And then we always encourage them, if anything urgent's coming up, to call 911, contact your therapist if needed. You know, so yeah, just talk about all that, those aftercare instructions. So if you're thinking of integrating CAP into your practice, just this is a very brief introduction. So yeah, this is just a handshake, this training. If you're interested, I recommend continuing to do trainings, learn from other practitioners. I recommend doing an experiential training if possible, if you don't have experience with the medicine already, it's just like really helpful to have that yourself, because it can be so ineffable and like cryptic, I even say. And so it just helps if you know kind of what that feels like. Although it's different for everyone, but you have your own experience and relationship with the medicine, that helps, I think, be a good CAP practitioner. Um, Make sure you're working with experienced prescribing providers, people that you feel are being safe, are really vetting people. Consider you're doing your own CAP as a client, if that's indicated for you. I personally found a lot of help with CAP, especially like when I had postpartum depression with my first child. That's kind of like what I saw how effective it was for me, and that's also kind of like what sold me on this model too. Always encourage people to start low and go slow. Not only in, I mean, you're not dosing anybody, but that's a good phrase to remember for like dosing ketamine, like the prescriber will say that. But also just with integrating CAP into your practice. Some people, I've done like 4-day trainings and people are like ready to open up the gates and start their CAP clinic like next week. I just say like go slow, start with like one person, get to know how it works with that person, and then like expand out. Um, a good way to do it is to start by doing integration therapy. So maybe somebody's doing CAP or like Spravato on their own, and you do the integration. So that's just a way to get to know what ketamine experiences are like. Um, or also like with other medicines, if people are doing underground work or going outside of the country or going to other states to do like psilocybin, doing integration therapy with your own existing clients is a great way to um, just learn what it's like to work with people in non-ordinary states of consciousness. I always encourage people to check to make sure your malpractice insurance covers CAP. I know CPH does not. That's what I used to have. I have HPSO now, and they do cover it. But it's also good to check with yours and get it in writing that you're going to start doing CAP and is it covered. Um, and it's always great to network and connect with other providers. It seems like in Salt Lake, at least, there's a lot of people that do CAP. And so, yeah, like know who else is doing CAP, especially people who are doing it in a way that you agree with, and you can bounce ideas off each other, hope maybe even join a consultation group. I do co-facilitate a consultation group. It's virtual, so there's people from all over the country. There's probably about 8 or 10 of us. Once a month on a Friday. It's usually like the third or fourth Friday of the month. So if you're interested in that, I'd say half the people in there are CAP only providers and the other half are working in the underground. And so if you're interested in that, it's free. Feel free to reach out and yeah, or find your own or make your own. I think it's just really important to talk about this. I also love being part of a group practice because there's about I think like 8 of us in my group practice that do CAP, and we also meet monthly to talk about our CAP program. Like, do we need to change the intake paperwork? What are you guys seeing? Or we talk about wins, like this one client was feeling this way and now they're feeling this way. And so it's just great to be connected with other people doing the work. Okay, that's all I have. Any questions? I'll just also, there's my references and I'll send these to you. There's my personal website, and then my practice in Salt Lake is Soma Psychotherapy, if you want to get the QR code. And then my Tucson practice, we do ketamine-assisted psychotherapy CAP provider trainings. We have an online portion and then we can do an experiential. And usually, like once a year, we do a retreat style training. We don't have like a set time to do that, but if you want to stay tuned, you can subscribe to our newsletter. And we also do CEUs on this topic and others. That's it. I have no idea what time it is and if I've gone too fast or slow.
You are
Sorry.
you are right on time. That was
Oh,
perfect.
good.
Yeah, I have a question for you. So
Okay.
obviously with the psychedelic dosing, so when is it that you incorporate the bilateral? So you don't do it in integration, you wait until
I mean,
you do it in
you
integration.
do.
Okay.
Yeah.
Okay, you just don't do it when the substance is ingested for that session.
Yeah, I don't recommend it for a psychedelic dosing.
Right.
I think it's yeah, people are in their own world.
Right.
It's like, you know,
Okay.
um, yeah. Does that answer your question?
Yes. And so then in the integration session, is it basically doing EMDR on something that came up kind of in the psychedelic session?
It could be, or
Okay.
it could also still be,
Whatever you're working on it
yeah,
originally.
whatever targets they were already working on, or
Okay.
you know, that it's cool when that happens. When some maybe like, or if they've already done EMDR and then they do CAP and like the same memories are coming up.
Right.
And you can talk about how maybe it was different on ketamine or do more EMDR on it if it's still not cleared. But yeah, it could be what came up in the session, or it could be like not related to anything that came up in the session.
Okay. Perfect. Thank you.
I have a question, and you've pretty much answered it, but I'm thinking about, EMDR can be so transformative and so insightful. How does ketamine enhance EMDR? Or how does EMDR enhance ketamine? I mean, what do you see that's different with this process than straight EMDR?
Uh-huh. Yeah. Let me see how I can explain like what I've seen.
Mhm.
I mean, I think like that like anxiolytic effect or like that like a little bit dissociative or like distancing effect. I don't know if that makes sense, but like for example, I've had clients that or who have done EMDR with me, who have done CAP with me, and then we do CAP EMDR. And like one client in particular, I'm thinking it's like she was remarking on, it was like she was watching herself do EMDR when she had a little bit of ketamine on board. So there was like even a little bit more of that like witnessing consciousness,
Mhm.
where they're kind of like they're doing it and they're seeing it differently. Like they're seeing
Mhm.
how they're even doing EMDR differently. Um, that's one way I've seen it enhance it. Um, and then, like I said, because it like um, it's like a little anxiolytic. Like sometimes people can, like I said, it widens that window of tolerance, so they can like
Yeah.
go longer. They can go a little bit deeper. They can like stay with it um, a little bit more easily with the ketamine on board.
Does it kind of take out the analytical coming in and telling the story as opposed to just allowing the flow of the EMDR to happen?
Yeah, it could.
Yeah.
Um, Yeah, it's interesting that you said that because I'm even thinking of that client that was like, oh, it's like I'm watching mine do it. So it's almost like there was like a little bit more of the
Hmm.
observer or analyzer, but
Hmm.
it wasn't like judging or it
Ah,
was
okay.
just witnessing. So yeah, I think
Yeah.
so.
Interesting. Thank
Mm-hmm.
you. Good
You're
information.
welcome.
Thank you.
Good.
Okay, I
And
have
remind me, oh, Mary, remind me of your experience, or have you haven't combined ketamine and EMDR yet? Okay.
No, for my own personal, I use it only for medicine and I do the intermuscular. And
Mm,
so there is some processing that goes on, but that's not what my focus is. So this is interesting to me because I've done so much EMDR and IFS with my own therapist that
mm,
I just don't feel the need to do more therapy with it, but maybe that's just my
mm.
contrariness. I don't know. So I'm curious. Yeah,
Uh-huh.
yeah, yeah. But I'm using it you know, um, for the depression, the severe depression that I have. So more
Mm-hmm.
medicinal than,
Hmm.
I don't know, exploratory. It's been amazing.
Hmm.
It's been incredibly helpful.
Good.
Incredibly
Yeah,
helpful. So yeah,
that's great.
yeah,
Yeah, and I think if you feel attracted, to trying it with EMDR, you could do that. I have like I did the training, the CAP EMDR training, and part of that was recommending practicing on each other. So I had another therapist practice on me, and I did it for her. So I got to experience it that way. But then I did actually have my personal therapist who I've done EMDR with. She's not trained, but I was like, I'm so trained. I feel comfortable if you're comfortable. And she's like,
yeah.
I guess so. And so I did ketamine and she did EMDR. I mean, she's like,
Mhm.
I wouldn't have even known you were on anything. And I was like, yeah, it's
Mhm.
because it's such a low dose. But
Mhm.
for me, I was like seeing it so differently because I had the ketamine on board, you know?
Fascinating. Okay.
hmm hmm
Yeah. Thank you.
Yeah. Other questions?
There's a question in the chat. Have you used CAP with dissociative disorders? If so, what kind of outcomes have you seen?
Oh, I have not personally, unfortunately. Let me think if others in my practice have talked about that. I'm just thinking about, a lot of times dissociation is seen as like, I don't even want to say negative, but it's like something that's undesirable. They don't want to be doing this anymore. It's scary when it happens. And that comes up with ketamine too. It's like, oh, it's a dissociative. You're gonna possibly dissociate. And like, is that tr gonna be traumatizing or is that, uncomfortable? Like I said, I don't really have direct experience with that, but like people have described the dissociation that happens with ketamine as I don't almost like reparative because it's like they know it's going to happen or it could happen and they and because of that because it's like that anxiolytic it's like not scary for a lot of people. Some people it's scary, but that's rare. Um it almost like I don't want to say heals it, but it's like not as negative to them anymore. I don't know if that makes sense, but that's the little bit experience I have and like the conversations I've had around it. That's what I'm getting from it. And it's almost like a choice, like they're choosing to go into this and possibly dissociate. So it's like that's maybe some getting some agency in that. Amanda, do you work with dissociative disorders a lot? The person who asked the question. It's okay if you don't want to unmute, but just curious. Or if you've used ketamine at all with those clients.
I
Sorry, I was
also,
trying to figure out how to unmute.
Oh,
Apologies. Yes, I've
it's
I've
okay.
had a couple of clients with dissociative disorders that have found it really helpful for parts work. Just
Nice.
exactly what you said. I was just wondering if you had the same experience. They found it very
Mm-hmm.
reparative, and I was very nervous um, when they said I want to go get ketamine and I want to try it. I found myself feeling like, oh no. But it was
Mm,
interesting. Yeah, actually, it was just two clients, but they both came back and said, I did dissociate. It was very intense. They both got IM and
mm.
it was very helpful for them,
Yeah.
especially is in disarming protector parts, which is kind of what we wanted to have happen.
Mm-hmm.
So
Yeah, that's cool. I will say too with IM, it happens more or like more of that like scariness happens because it is like a blast off. It's like you get the
yeah,
shot and then it's like boom, now you're in it. Whereas with the troche, it's like a little bit more of a slower rise and fall. So sometimes like if somebody is scared of that, like we'll recommend doing the troche. Or maybe they want to address it. They're like, I just want to do it. That's fine. It's up to them. But I educate people on that and like let them know it. You could avoid that if you want by doing not maybe totally, but a little bit more of a slower incline and decline.
yeah, definitely.
Yeah.
Thank
Kristen,
you.
were you starting to say something too about it?
I anecdotally heard from a colleague that she had a DID client do it. And, I don't know how much preparation they had done. I imagine quite a bit. And the parts got together and met everyone and, that it was a positive experience. So again, I would probably feel the same way with my real dissociative clients because it would be unknown territory for me and them. But maybe again, if we both feel someone's ready, start at the lower dose. And like you
Mm-hmm.
said, low and slow or whatever you said.
Mm-hmm. Cool. Yeah. Good questions. Any other questions?
Well, I have one more question. So for your psychedelic doses versus the psycholytic doses, for all of your psychedelic doses, do you do 3 hour sessions?
I say like at least 2 to 3. Some people are fast metabolizers,
Mhm.
but and then with IM it's also faster. So with IM it could be done in 2 hours, I think. With the sublingual, I try to leave at least 3. Sometimes we're done in 2 or 2.5. And we don't have to drag it out. But yeah, I leave that much time. Just it, and some people like are still feeling it on their way out at 3 hours. Like some people are slow metabolizers, or if they swallowed the medicine. Yeah. Yeah, I wish we had a room, or like we've said this before, like if there was like a room that they could go like just lay down in or chill out in for a while, because some people are not ready to like go back out into the world. But we only planned for 3 hours and they don't want to keep paying for our time and stuff too. So we don't have that option though.
There's another question in the chat. Have you seen any gains with the chronic illness population or chronic pain?
Yeah, we have several clients in our clinic that have either chronic illness or pain. Ketamine, well, it's an anesthetic, but it was being used in like in the IV clinics for pain management, and that's where they started seeing the antidepressant effects. That's kind of how they discovered that ketamine works with depression, because it was, and of course when you have less pain you're going to have less depression too, but it's like they're like, oh, is this just because they have less pain, or is the medicine itself doing something to the depression? And that was like in the 90s. But yeah, so it definitely can help with chronic pain. Like people admit or endorse that like that day their pain is different. Some people are on a pain protocol, like where they'll go for like it's a longer infusion. It's lower. It's like it's an infusion, but it's not the psychedelic dosing. But that can really address chronic pain. And then the chronic illness piece, just like the grief, the acceptance, um, that that comes a lot with the ketamine work of just, yeah, this is my situation, and just kind of that feeling of okayness, like I can handle it, I'm okay with this, I can get through this. I've seen that for sure. Well, thank you all for your presence and your questions, and I'll send the slides, and feel free to reach out to me if you have follow-up questions or want more resources. I like sharing about it. So yeah, thank you.
Robin said in the chat, thank you. This training was validating for me as I introduced CAP to our clinic 2 years ago. I have learned so much throughout the process and find art, which uses bilateral stimulation and CAP, extremely complementary as healing modalities.
That's awesome. Yeah, I am not trained in art, but I've heard it's similar like to EMDR, so that's great. Very cool.
Well, Kate, thank you so much for this presentation. I will send you, are you okay if I send out your contact information too for
Yeah,
anybody who has questions or wants to join that consult, that monthly consult group of you?
yeah,
Okay.
yeah.
Well, yeah, thank you so much thank you everyone for attending, and thank you, Kate, for the effort you put in on this presentation and spending your Thursday night with us. It was very informative. And I'm personally getting trained in ketamine, so this was perfect for me. So I'm like,
Yay,
like,
cool.
excited to see what's next. Just a reminder for everyone, if you are wanting that CEU, again, please email TICNutah@gmail.com. I can also send you Kate's slide slides and contact info. And with that, I hope everyone has a great rest of their Thursday evening.
Bye. Thank you.
Bye.